about generally the situations, unfortunately, like I can give this medication, I can give this medication, I can try this medication, then examiners usually are not very happy. Whatever they are practicing in their private setup or public sector or wherever they are, but in exam, they expect appropriate answer as far as the theoretical aspects are concerned. So handling the question is usually difficult, but it's not difficult if you know what to say. So if there is a kind of a situation where examiner, you feel that this person is suffering from schizophrenia and now he's developing obsessive compulsive disorder, or your diagnosis is schizophrenia. So if there is a comorbidity, then you have to justify, then you have to make sure that everything is okay. But I will still say not to start pharmacological management, focus in exam situation by telling to the examiner that I will reassess, go for more psychological investigations, social investigation, biological investigations, confirm my diagnosis, and then proceed with the further management strategies, which could be pharmacological, psychological, and social. If I'll be able to respond in that way, examiners usually accept, as I always say, that there is a shortage of time in exams. So how you defend yourself matters a lot. Of course, everything is not possible. So you won't be able to tell them all the management strategies that you are using for these kind of people. So you have to play a safe game in the exam so that the examiner agree with you and they pass you. So the target is to pass the exam. Let's start with the subject. So Bismillahirrahmanirrahim. I'm sorry, this forward was a little bit longer than expected. Schizophrenia and comorbidities, this is one of the topic, and the next topic we will definitely go for other interventional strategies in psychiatry like RTMS and vagal nerve stimulation and all that stuff. हर्फ हर्फ रट कर भी आग ही नहीं मिलती, आग नाम रखने से रोशनी नहीं मिलती, आदमी से इंसान तक आओगे तो समझोगे क्यों चिराग के नीचे रोशनी नहीं मिलती. Unfortunately, we always try to go for the shortcuts. There is no shortcut in life and there is no shortcut in psychiatry. Psychosis, when we say psychosis, I mean schizophrenia and related disorder. They have multiple association with other diagnoses. One coexisting independent OCD in this situation, which was mentioned in the group. Second is that its obsessional symptoms sometimes are the prodrome of psychosis. Third situation, that recovering psychotic patient develops obsessive rumination. So psychosis and obsessive compulsive symptoms resolution. And there is de novo obsessive compulsive syndrome or symptoms along with psychosis. So, and the neuroleptics also, of course, they have some role to play, especially the atypical antipsychotics, they have some role to play. So in schizophrenia, there are multiple situations where obsessive compulsive disorder can coexist, simultaneous, developing after the treatment of psychosis, developing as the psychosis is remitting, developing as, again, in combination with psychosis, neuroleptic induced obsessional symptoms, and coexisting independent OCD. There are multiple situations. Schizophrenia and OCD have lots in common as well. Like positive symptoms of hallucinations and delusions are in schizophrenia, but obsessional magical thinking, which sometimes is very confusing when we are eliciting them and trying to justify them. They appear like delusions, but they are not delusions. They are obsessions and they are magical thinking. Second, affective symptoms like depression and anxiety can exist with OCD and with schizophrenia as well. When there are disorganized symptoms of schizophrenia, bizarre behaviors, oddity, blah, blah, then of course there is no doubt about diagnosis of schizophrenia. But sometimes the motor symptoms like stereotypies, mannerisms, tics, they mimic the situation where we feel that they are compulsive rituals, but they are actually motor symptoms of schizophrenia. So that is also a gray area. The slowness is another component. The obsessive compulsive disorder have obsessional slowness. And schizophrenia is also having psychomotor retardation. So this is a gray area between both the diagnoses. Then ambivalence and ambitendance, which is again a symptom of psychosis. There is indecisiveness in OCD. So people do have pathological doubts where they are ambivalent, but actually they are not having the ambivalence as a symptom, but they are indecisiveness and psychological pathological doubts. Then is the insight. Most of the obsessive people, they unfortunately they lose insight. This never means that they are having psychotic illness. They are still OCD, having an insight or without insight. But schizophrenia, there is no insight as well. This is another gray area where people find it very difficult to justify whether this is an OCD with lack of insight, or this is schizophrenia with lack of insight, or it is coexisting both conditions with lack of insight. And negative symptoms, of course, they are not seen in OCD, but sometimes yes. So that is also tricky. Okay, there are some questions. Can you give an example of magical thinking of OCD that can be confused with a delusion? Okay, now you see, magical thinking, Harry Potter, whosoever has watched Harry Potter, they know what the magical thinking is. Magical thinking is sometimes a hypothetical situation where you can do things which are beyond human imagination, which are not in beyond human powers, rather imagination. So something which can be done beyond human powers is a magical thinking, like flying, like playing with a fireball in space, or something like that, which is beyond human powers to do. If person starts thinking and imagining those situations which are happening in a real life situation to the patient, that is magical thinking. And of course, it is sometimes very difficult to discriminate it from the delusional disorder. But if you overall see the history, the presentation, the general communication with the patients, of course, there are points more in favor of OCD rather than schizophrenia. But these are tricky situations where you need lots and lots of assessment rather than intervening straight away. So my point stays the same, that if you really want to treat appropriately, then you should know what you are treating. If you don't know, then things are complicated. Schizophrenia is a clinical heterogeneity of disorder which is indisputable. There are virtually no two patients present with the same constellation of symptoms. So unfortunately, there are multiple symptoms, backgrounds, social backgrounds, cultural backgrounds, interactive backgrounds, personality backgrounds, blah, blah, blah. So there are so many things in the background, and then the patient comes with the symptoms, certain symptoms, which you feel that this person is suffering from schizophrenia. But making that assessment and assumption from various class, culture, social, personality, background, and coming to the conclusion to treat schizophrenia is sometimes tricky. So, and it's not always the same. Moreover, even in the same patient, symptoms can show dramatic change over the time. Some people present initially with different symptoms, and when you start treating them, next time they come in and you try to talk to them, there are different symptoms. For example, negative symptoms develop over the period of time, or the deficit symptoms develop over the period of time, and they change, right, from one symptom to another. This is more tricky. They change because of your interventional strategies, they change because of the circumstances changes, they change because of the environmental factors, they change because of the psychological factors. It's so much confusing. But you have to understand that this is schizophrenia on the basis of this, and these symptoms may change the course over the period of time. Comorbidities. Now, this is another very tricky situation that a patient of schizophrenia can have comorbidities. Yes, this is complicating clinical picture of schizophrenia, as well as we have to understand the boundaries and etiology of the condition with substantial psychiatric morbidity. So if you have data, if you have justification, if you have the symptoms, then it's easier for you to move forward. Otherwise, it will be complicated. So depression, anxiety, substance abuse are the common comorbidities in schizophrenia, and we all see them, and they in turn perturb the clinical picture. For example, depression can cause secondary negative symptoms like panic attacks like situation, or they can worsen the paranoia because of the affective component, or the patient starts abusing cannabis and marijuana and chars and hashish and all that stuff, and then they can worsen the positive symptoms and disorganization symptoms as well. So that is again tricky. As I'm saying time and again, your basic diagnosis and evaluation matters the most. If you are firm with your diagnosis, the management strategies will be comfortable. If you're not fine with that, then of course you will mix all these things and be confused. Conversely, depressive symptoms seen in the context of a florid psychotic relapse often resolve with the treatment of the positive symptoms, but may reemerge in the post psychotic state and in turn worsen the longitudinal course of the illness. This is again strange because when you start treating depressive symptoms with antidepressants along with antipsychotics, then sometimes this is not a good way to move forward in the beginning. I always say that there is a hierarchy of the diagnosis in classification system. So schizophrenia is at the top. If you make a diagnosis of schizophrenia, and mood disorders are number two. If you diagnose schizophrenia, then you don't treat the things below that. You treat schizophrenia first, and when the schizophrenia is treated, the rest of the symptoms can be treated afterwards. But if it is a partially treated schizophrenia and you add up on pharmacological interventions related to the symptoms evolving afterwards, it will be a chaos. The prognosis is compromised, outcome is bad, and because this is a chronic disorder, then there is lots and lots of problems afterwards in patient's life. If I see a patient of schizophrenia with some depressive or anxiety symptoms, I will treat schizophrenia, make sure that he goes into the remission, and then address the rest of the things, ideally speaking. And this is what I promote as well. Now, the difficulties usually are still there. Nosologists have great difficulty dealing with the complex sets of symptoms. Well, yes, I agree. Most of the time, we are not able to ascertain that this symptom is schizophrenia symptom or something else. And we have to, again, keep on, hovering the patient with multiple kind of medication. That is not the answer to the problem. The answer to the problem is to reassess, to revisit, to do serial mental state examination, to move forward with psychological, social, and other interventional strategies till the time I'm sure that the patient is symptom free or relatively in a remission state where I should try to treat the comorbidities. So hierarchy, schizophrenia treated first, affective disorders treated second, anxiety disorders treated last, and then later on other disorders associated with it. Generally, an implicit or explicit hierarchy is embraced such that schizophrenia trumps depression and anxiety, right? So you treat schizophrenia, and most of the time, the depressive and anxiety symptoms resolve by itself, most of the time. This is the literature favors it. And if you want me to quote you references, I can do that. I have 58 studies quoting how to treat anxiety and depression in schizophrenia. 58 studies. There is 114 studies in reputable indexed, high index journals related to schizophrenia and OCD. And I have all the references. I have 178 references. And this was another reason why it took me so much time to prepare for this presentation. Well, I like it because in that way I have to study as well. And I always love that these challenging situations should be addressed appropriately. Or if no primary can be determined, resort is made to labels such as schizoaffective disorder. Now, imagine this statement. This is such a powerful statement. If no primary can be determined, how is that possible that you miss the primary and you are treating schizoaffective disorders? Ideally speaking, there has to be a primary or even schizo-obsessive subtype of schizophrenia. Now, this statement, I'm quoting it time and again, that this statement is very crucial. This means that either we have understood everything or we haven't understood anything. So the primary diagnosis is the key to the success of a psychiatrist and of a patient as well. A good psychiatrist will focus on the primary, and the clinicians sitting otherwise, non-academicians, will focus on symptom resolution. I won't go for symptom resolution and symptom treatment. I will go for the treatment of primary psychiatric morbidity, and the rest of the things will be addressed automatically. This is what is the ideal situation. People may disagree with that, but I have references related to it. An alternative approach, refined and classification system of mental disorders, is to consider these symptoms as part of another axial diagnosis that is occurring alongside schizophrenia or this category. But again, making this as a comorbid condition simultaneously occurring, we have to have a strong basis. Under this scenario, the patient has two major conditions, and these have co-occurrence, perhaps for some etiological reasons, common to both disorders. So the etiology has to be same, the presentation has to be the same, and the diagnostic classification and criteria should be fulfilled, and both the disorders are simultaneously existing there, and then we say this is either schizoaffective or schizo-obsessive. Usually, in majority of the cases, this is not true. This is something, a rare situation. So in exam, if I'll be asked to justify my diagnosis, I will always say that this patient is my primary working diagnosis for this patient as a differential is schizophrenia. However, as this patient is having obsessive symptoms and affective component, I will try to reassess the patient, reevaluate the patient, take the history in detail, make sure that I haven't missed anything in the history, make sure that etiological factors are highlighted appropriately. I will make sure that I understand the precipitating and predisposing factors, and then I will assess the maintaining factors, and then I will treat the comorbidities if there are no other possibilities. This will be my approach. And ideally speaking, this is the approach that examiner wants to hear from you. I hope I'm making sense. Anybody who feels that I'm not making sense, please stop me. Don't hesitate. Okay. I would love to if you intervene and ask me a question. Now, other diagnosis as an integral component. Bermonzon et al. This article was published in American Journal of Psychiatry, provocatively proposed that we stake out the mid ground. Usually, this is what we do. They suggest that the psychiatric comorbidities are so common that they might be integral to schizophrenia. To a large extent, or current research in clinical trials and neurobiological studies is increasingly coming in line with this proposition because now such studies support broad inclusion criteria of all comers. So schizophrenia patients can have panic disorders, PTSD, OCD, depressive, pedophilia, or maybe sexual orientation disorders as well. Well, this is one theory. It's not all. There are references related to it. There are references against it as well. The schizophrenia patients whom we see in everyday clinical practice who have prominent anxiety symptoms or may also have depressive symptoms and also abuse drugs and alcohol. So in clinics, this is the common presentation. In outpatient department, this is a common presentation. The patient comes with the diagnosis of schizophrenia. However, they are abusing the substances, they are taking the alcohol, they are taking the drugs, they have some depressive symptoms, they have some anxiety symptoms, and it's a mixture of all. So we can say that they are coexisting simultaneously. But the points in favor of this argument are less as compared to what I was talking earlier. Relevant epidemiological, genetic, familial, neurobiological, and therapeutic literature, we ask whether comorbidities should be considered. Well, the points in favor for that are to have simply by chance co-occurred with schizophrenia. Whenever we say by chance, it's the toss of the coin, and the toss of the coin is unpredictable. So the points in favor of this are relatively less. To have manifested secondary to the core disorders of schizophrenia, well, the chances for this are relatively higher than the first one. To have manifested, because schizophrenia is more common in this core disorder. So people who have prodromal symptoms of OCD, anxiety, depression, later on they were full-blown schizophrenia. Sometimes the picture is complicated. Are consequences of some underlying shared liability to both sets of disorders, which again is on the basis of neurobiological and genetic situation. Schizophrenia and anxiety. Let's talk about something comorbidities of schizophrenia and anxiety. So there is an increased prevalence of anxiety disorders among the patients with schizophrenia compared to general population. So in general population, usually the anxiety disorders are how much prevalent? We can say 1 to 10% in general population. So every 10th individual will have an anxiety disorder, or every, if it is 1 in 100, then probably 1 in 100% will have anxiety disorder. And schizophrenia is 1% in general population. This means that 1% in general population, 1% in 1,000 is suffering from schizophrenia. He may have the chances of having simultaneously anxiety disorder of 0.01%. So every 100 schizophrenia patients, out of them, one patient will have simultaneously anxiety disorder, right? Because that is what the prevalence studies suggest to us. These include panic disorders, PTSD, OCD, GAD, and social anxiety disorders as well. Prevalence estimates are influenced by heterogeneity among definition of symptoms, and rating instruments used for the diagnosis. So our assessment methodologies matter a lot when we are talking about the comorbidities and simultaneously existing condition. Other diagnostic issues complicating the study of anxiety in schizophrenia are that the symptoms may occur spontaneously, intermittently, in direct response to psychotic symptoms, and or as a side effect of antipsychotic medications. We always forget that whatever the treatment we are giving to the patients, that can also give some problems to the patients. We don't want to accept it, but it's a reality. Panic attacks and panic disorders in patients with schizophrenia. Evidence from 3 studies suggests that the panic symptoms may be more common in patients with paranoid schizophrenia, only paranoid schizophrenia, compared with other schizophrenia subtypes or schizoaffective disorders. Well, schizoaffective, again, doubtful, but yes. Furthermore, panic attacks were frequently related to paranoid ideations in these studies. All 3 studies and major studies, not having smaller samples. One of the study was having something around 1100 patients, the other study was having 900 something, and the third study was having 600 patients, something like that. So it was a big, again. Bermanzon et al. Described the potential for a relationship between panic attacks to paranoia. If you are interested in it, there is a whole detail available, and it's a beautiful article written, and you can understand the actual dynamics of having anxiety and schizophrenia. Comorbid panic symptoms may be associated with more severe psychopathology, as well as increased risk of suicidal ideation and behavior, and may also increase vulnerability to comorbid substance abuse. So this means that if a person is having schizophrenia and he is suffering from paranoid schizophrenia, the symptoms of the panic disorder along with schizophrenia will worsen the outcome because there are more chances of suicidality, more chances of substance abuse, more chances of having mixed psychopathology. But overall, if you treat schizophrenia, all these symptoms will disappear. That is again important. PTSD, trauma histories are common in patients with schizophrenia, and childhood trauma is a risk factor for psychosis. We all know that. Most of the patients who are suffering from schizophrenia have these kind of problems. They have difficult childhood, they have social problems, they have difficulty in schools, in other interacting with other people, so they are more traumatized. So patients with schizophrenia may be at risk for exposure to trauma due to illness-related features, environmental influences, and or comorbid substance abuse. Many factors complicate the diagnosis and investigation of co-occurring PTSD in schizophrenia, including the presence of psychotic symptoms within the context of PTSD or PTSD, such as re-experiencing the same situation. It's a complex situation, very complex situation. And again, as I said to you earlier, I will re-emphasize and reiterate that most of these people of schizophrenia, when we are treating them with appropriate medication, appropriate psychological intervention, appropriate social interventions, and the prognosis and outcome is compromised, I will revisit my diagnosis. I will try to reassess the other factors associated in their lives and try to address them before I will jump onto other complicated medications. ख्वाहिश से नहीं गिरते फल झोली में, वक्त की शाख को मेरे दोस्त हिलाना होगा. कुछ नहीं होगा अंधेरों को बुरा कहने से, अपने हिस्से का दिया खुद ही जलाना होगा. We always find shortcuts for a better outcome and prognosis, but we are playing with human lives, and human lives are important to us. Don't be a psychiatrist. First, be human and then be a psychiatrist. I always ask this question from my residents and my trainees. If I am getting a treatment, will I prefer 13 medications, 10 medications in my prescription, or I will prefer one medication in my prescription? I will say I will prefer one drug. I won't go for polypharmacy. I want my diagnosis and I want one treatment for my diagnosis. But usually this is not what is happening in a real life situation. So far, any questions? I don't see any questions.
Yes, yes, sir. Yes, sir. I have a question.
Go ahead. Go ahead.
सर एक की बड़ी कॉमन सी कन्फ्यूजन होती है कि अगर हमारे पास कोई पेशेंट प्रेजेंट किए हैं जिनको जैसे हमें समझ नहीं आ रहा कि वेदर इट इज़ डिप्रेशन और नेगेटिव सिम्टम्स ऑफ स्किज़ोफ्रेनिया, तो उसमें हम क्या हमारी क्या स्ट्रैटेजी होती है, हमें क्या करना होता है? पहले हम मतलब उस वक्त हम कैसे प्रोसीड करेंगे, क्या चीज़ ट्रीट करेंगे? एज अ केस ऑफ डिप्रेशन ट्रीट करेंगे या एज अ केस ऑफ स्किज़ोफ्रेनिया ट्रीट करेंगे? पता नहीं, दिस इज अ कंफ्यूजिंग सिचुएशन।
इसी बात को मैं बार बार इस प्रेजेंटेशन में आपको समझाने की कोशिश कर रहा हूँ। हम ट्रीट नहीं करेंगे,
ओके,
हम रीअसेस करेंगे, हम कोशिश करेंगे अपना डायग्नोसिस फर्म बनाने की, हम रीविजिट करेंगे, हम रीअसेस करेंगे, हम रीएवैल्यूएट करेंगे, हम सीरियल मेंटल स्टेट करेंगे, हम साइकोलॉजिकल इंटरवेंशंस का असेसमेंट्स करेंगे, हम बायोलॉजिकल असेसमेंट्स करेंगे, और जब हम अपना फर्म कन्विक्शन से डायग्नोसिस बना लेंगे फिर हम ट्रीट करेंगे।
ओके, ओके।
सो अगर आपको कंफ्यूजन है कि ये नेगेटिव सिम्टम ऑफ स्किज़ोफ्रेनिया है या ये कुछ और है, वक्त दें, असेसमेंट पे टाइम ज्यादा लगाएं, बाद में इंटरवेंशंस होती रहेंगी। मेरा पॉइंट समझ रहे हैं? दिस इज व्हाट आई एम ट्राइंग टू फोकस मोर।
ओके,
Right? Okay, good. So Maru has a question. Yes, go ahead, please.
Assalamu alaikum, sir.
Walaikum salam.
Sir, thank you for your elaborative presentation, but I am a little bit confused कि अगर कोई ऐसा पेशेंट आता है जिसमें हमें OCD के भी सिम्टम प्रोमिनेंट मिल रहे हैं एंड स्किज़ोफ्रेनिया के भी मिल रहे हैं, बिकॉज आई हैव सीन सच पेशेंट इन माय ट्रेनिंग टू, और उसको 2 to 3 years फॉलो किया, अल्टीमेटली ही वाज शिफ्टेड टू क्लोज़ापीन। तो इज इट सेफ कि हम स्किज़ोफ्रेनिया कोमॉर्बिड विद OCD उसका डिफरेंशियल या डायग्नोसिस बनाएं या सिर्फ स्किज़ोफ्रेनिया रखें?
अच्छा, अब मैं फिर उसी बात पे फोकस करूंगा. It's a good thing that you are asking the same question and again. I'm trying to explain it again and again. If you see a patient of schizophrenia, right, and you assess the person and you feel that this person is suffering from schizophrenia and he is having OCD. वैसे मैंने अभी OCD आगे cover भी करनी. I'm still short of some slides. अभी मैं वहाँ पहुँचा नहीं. मैं मज़ीद इस पे बात करूँगा. OCD मौजूद है, स्किज़ोफ्रेनिया मौजूद है, 3 साल से पेशेंट ट्रीटमेंट ले रहा है, ठीक नहीं हो रहा. मैं क्या करूँगा? मैं ये करूँगा कि मैं उसकी दवाइयाँ टेपर ऑफ करूँगा, मैं उसको ड्रग फ्री स्टेट में लेके आऊँगा, मैं उसको हॉस्पिटलाइज करूँगा, मैं उसको रीअसेस करूँगा, मैं उसकी साइकोलॉजिकल इन्वेस्टिगेशंस कराऊँगा, मैं उसकी सोशल इन्वेस्टिगेशंस करूँगा, मैं उसकी प्री मॉर्बिड स्टेट देखूँगा, मैं इटियोलॉजिकल फैक्टर्स को रिविजिट करूँगा. मैं सारी चीज़ों को असेस करके बजाय इसके कि दवाई 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 और क्लोज़ापीन पे पहुंचूं, मैं रीअसेस करूंगा. और जब मुझे फर्म कन्विक्शन से डायग्नोसिस एस्टैब्लिश होगा, मैं फिर ट्रीट करूंगा. मैं अभी आगे आता हूं, आपके सवाल का मजीद जवाब क्लियर होगा इन माय नेक्स्ट फ्यू स्लाइड. ना क्लियर हो मुझे दोबारा याद कराना.
ओके सर, थैंक यू सर.
गुड, लेट्स मूव फॉरवर्ड. OCD. Obsessive compulsive symptoms and OCD have been frequently studied in patients with schizophrenia, with the majority showing an increased rate of both OCS and OCD in schizophrenia? जो आपका question था. A study from ECA survey found 12.5-fold increased odds of having OCD given a diagnosis of schizophrenia. Just imagine 12.5-fold means more than 100%, right? By contrast, another study from this survey found a 3.77-fold increased risk of schizophrenia among the patients with OCD. यहाँ पे उल्टा हो गया. यहाँ पे OCD के patients को schizophrenia का diagnosis दिया जा रहा है, suggesting that for some patients the presence of OCD may be a part of prodromal psychotic state. अब ये दोनों स्टडीज एक दूसरे के ऑपोजिट जा रही हैं, ठीक है. एक में कह रहे हैं स्किज़ोफ्रेनिया में OCD आ रहा है, दूसरे में कह रहे हैं OCD में स्किज़ोफ्रेनिया डेवलप हो रहा है, और शायद वो स्किज़ोफ्रेनिया ही था लेकिन OCD से प्रेजेंट कर रहा था शुरू में. A total of 36 studies investigated the epidemiology of OCS, obsessive compulsive symptoms. Now with ICD-11, I will say OCRDs, obsessive compulsive recurrent disorders, and OCD among patients of schizophrenia. The prevalence of OCS was 10 to 64%. मैंने अपनी स्टडी भी शेयर की थी और मैंने यही परसेंटेज कोट की थी. There were more than 60% symptoms in patients suffering from schizophrenia. Obsessive compulsive symptoms in schizophrenia, anything between 10 to 64%, which is more than half, right? So every other patient that you are seeing will be having some kind of an obsessional phenomena happening during his schizophrenia course. Overall, 31.7%, vary widely across these studies, may have been overestimated due to difficulties in distinguishing clinical obsessions and delusion. गलती कहाँ होती है? गलती assessment में होती है. हम delusions और obsessions की differentiation में गलती कर जाते हैं, और एक दफा patient label हो गया तो फिर चल पड़ा, ठीक है. और फिर अगला OCD. Several studies have suggested that OCS manifests as part of psychosis prodrome. Second, 2 studies found that the presence of OCS was associated with earlier age of onset of psychosis. 3 studies have found an 11 to 15.2% of prevalence of OCD in patients with first episode psychosis. It's not chronic psychosis, it's first episode psychosis. The presence of OCD also has a prognostic significance in patients with schizophrenia. Parenthetically, obsessive symptoms, as was the case with affective symptoms, were originally considered to be a favorable prognostic value. This does not appear to be the case. If the affective symptoms are there, if the obsessive symptoms were there, previously it was considered that the outcome and prognosis is good. Now it is proven that the outcome and the prognosis is unfortunately more compromised. Furthermore, dopamine and serotonin are the key neurotransmitters involved in the pathophysiology of both schizophrenia and OCD. We all know that. While substantial overlap in the neurobiology may well contribute to association between these disorders, a potential confounding factors in the epidemiological study of this association is that second-generation antipsychotics with serotonergic receptor blockade may exacerbate or produce de novo OCS in patients with schizophrenia. So whatever you are doing, you are worsening the symptoms of obsessive compulsive in patients with schizophrenia by actual intervention of second generation antipsychotics. This is not what I'm saying. This is what the literature suggests. Now, what to do about it? Taken together, several lines of evidence suggest that the patients with both schizophrenia and OCD may represent a schizo-obsessive subtype of schizophrenia, जो generally हम सारे accept कर रहे हैं और बोल रहे हैं, with differences in psychopathology, course of illness, and response to the treatment, as opposed to comorbid syndromes. The literature supports the possibility that in subgroup of patients with OCD may be part of illness of schizophrenia. Now, if OCD is part of the schizophrenia, if I revisit, re-diagnose, re-evaluate all the factors and feel that both the things were simultaneously there, the prodrome had the obsessive symptoms as well, OCD is now as well, again, I will say the same thing which I mentioned earlier. My ideology would be to admit the patient, to taper off all second generation antipsychotics, which usually we do give, taper them off, clear the patient with all the medication, reassess, reevaluate, and then move forward, rather than keep moving forward with the cross titration, stopping one, starting another. Don't do that. Again, schizophrenia and depression. I hope partially I have responded to your question, but I will come back again. The relationship
Sir,
between
there are 2 more hands raised.
Okay, go ahead. Okay, go ahead. Who wants to ask first? Yes. There is one guest user and Dr. A who have raised hands. So Dr. A should go first. Go ahead. Waiting. Dr. A.
Sorry, sir, but actually, my question was same as the doctor asked about the OCD, and so it was mistakenly raised. I'm just listening what you are explaining about the OCD and schizophrenia overlapping diagnosis, sir.
Okay. And what about the guest user? Yeah. Your question.
सर
No?
आई थिंक ये गेस्ट यूजर ने पूछा है क्वेश्चन और वो जो डॉक्टर ए हैं उन्होंने नहीं पूछा आई डोंट नो व्हाई तो आप प्रोसीड करें फिर
Okay. Coming back to the same. So furthermore, there has been ongoing and robust debate about the nosological status of schizoaffective disorder. Now, this is a tricky situation. There are lots and lots of debates throughout my career for almost 20 to 30 years time. Always people who've been trained by me, they have difference of opinion, but I'm of the firm opinion that I make a diagnosis of schizophrenia, and if I feel there are affective components, I never make a diagnosis of schizoaffective unless or until I have a clear, firm diagnostic criteria which is fulfilling both the disorders. I don't make it. I make a diagnosis of schizophrenia, I treat schizophrenia, and usually the affective components is addressed. Muller poses the question whether these depressive symptoms are part of the rich psychopathological picture of schizophrenia, which besides the core paranoid hallucinatory syndrome includes negative syndrome, a cognitive syndrome, and also a depressive syndrome, or whether depression and schizophrenia should be seen as a separate conditions in terms of the concept of comorbidity disorder, with varying definition approaches that make the literature very difficult to negotiate. And I absolutely agree with this quote. When we say schizoaffective, this means that our job is not completely done. This means that we have missed something in the history. This means that we have missed some predisposing factors. This means that we have missed some psychological and social factors. This means that we have missed some family history and premorbid personality that we are making the diagnosis of schizo effective. So it's a very debatable diagnosis of schizoaffective. Unfortunately, it's a shortcut. We make a label of schizoaffective. We treat them with multiple polypharmacy, and I don't agree with that. I'm sorry, but this is my viewpoint. People may disagree with that. Schizophrenia and depression. Bartels and Drake, there are two very famous names, suggested that depressive symptoms in schizophrenia be divided into three categories. One, depressive symptoms secondary to organic factors. So my schizophrenia patients can be suffering from diabetes, which can have depressive symptoms as well, or hypertension, or maybe something else. Two, non-organic depression intrinsic to acute psychotic episode. When a person is suffering from psychosis, the person is actually sidelined. They are cut off from reality. They lose insight. They are secluded. They are isolated. Their family treat them differently. They are human minds, which otherwise are functional, but they are psychotic. So this never means that they are not humans anymore. They still do have some emotional component there, existing there. And three, depressive symptoms that are not temporarily associated with acute psychotic episode, such as symptoms associated with prodrome or post-psychotic interval, as well as those symptoms that resemble depression that may represent negative symptoms of schizophrenia. So a patient may be having depressive symptoms as part of acute illness, as part of recovery process, as part of, again, partially treated schizophrenia, but schizoaffective, I will refrain myself, especially in exam situation, to label person with the schizoaffective. Treat schizophrenia and then assess what is the etiology of depressive symptoms and then treat that etiology. Don't treat them with polypharmacy. The schizophrenia and depression, antipsychotic medication themselves produce neurological side effects like Parkinsonism-like side effects. You all know that. They cause bradykinesia. They cause diminution of affective expression, masked faces, verbal delays, and akathetic restlessness that may be confused with the psychomotor retardation or agitation or depression. Antipsychotic drugs may also produce a primary dysphoria, possibly due to dopamine blockade and reward pathways, and it has even been suggested that these drugs are innately depressogenic. Have you ever tried taking an antipsychotic medication? I can assure you, if a normal person takes only 25 milligrams of quetiapine, they will knock him down to an extent that they will start feeling depressed with one dose. Be careful about these things. अपने हिस्से का काम किए बगैर दुआ पर भरोसा करना हमाकत है और अपनी मेहनत पर भरोसा करके दुआ से गुरेज करना तकब्बुर है. So first complete your own job, reassess, revisit, reevaluate, and then make the comorbid diagnosis. Otherwise, don't do that. Schizophrenia and depression, further telling you about it. This is just, again, my viewpoint. You may disagree with that, but this is, I am talking with references, and I can provide you all the references. I will soon upload one of the very good article related to the same topic, and it will help you a lot. People with schizophrenia are also prone to general medical comorbidities and substance abuse disorders, some of which also produce depressive symptoms. Certain negative symptoms such as anhedonia, abulia, alogia, amotivational, avolitional state, and social withdrawals can overlap with or spuriously suggest depression. Demoralization, disappointment, or loneliness following a psychotic episode may create lingering feelings of dysphoria and depression. unfortunately. So schizophrenia and depression, again, PDD has traditionally been formulated as a psychological reaction. This is post-psychotic depression, or loss or to psychological trauma of psychotic episode. Most of the people who have the psychotic episodes, when they are recovering or when they are passing through it, they do feel depressed as well. This never means that we should treat them with two medications, antipsychotic and antidepressant. Roth wrote that the depressive reaction that follows a psychotic episode is part and parcel of a total psychobiological reaction to a failure of the patient in some area of human relationship. How will I feel if I'm psychotic breakdown? How will I interact with my mother? How will I interact with my father? How will I interact with my wife? How will I interact with my children? And when my interaction with all these important relationships in my life are breaking down because of the psychotic symptoms, what effect it will bring to my soul and to my psyche. Of course, depression would be one of them. In contrast to early views that depression was associated with favorable prognosis in schizophrenia, I have already mentioned, the evidence speaks otherwise. Mendel et al. Followed 211 schizophrenia patients in the community for a year after a hospital discharge. The 25% of the patients who suffered depression in the first few months after discharge had a notably greater burden of symptom chronicity. Eve Johnson is a famous name in schizophrenia and depression, reported that the chronic patients who developed depression more than a year after acute recovery experienced more relapses than other patients. An old study of Swang and Correll and a more recent one by Sim et al. Both failed to reveal better outcomes in schizoaffective disorder than schizophrenia. So when you label schizoaffective, actually you are compromising the outcome and prognosis of schizophrenia as well. Contrary to the fact which was written in the books that if a person is having affective component in schizophrenia, there will be a better outcome and prognosis. Now the studies are proving it the other way around. Concerning the neurobiology of schizophrenia and depression and evidence of etiological and pathophysiological coincidence or overlap, the majority of the studies that might inform the topic utilized subjects with either depression or schizophrenia, but rarely both. While functional imaging studies of depressed patients have shown decreased prefrontal metabolism or decreased regional cerebral blood flow, those that directly compared RCBF changes during working memory tasks in schizophrenia and depressed groups showed substantial intergroup differences in the direction of greater reduction of RBF in schizophrenia than depressed subjects. So now that we have more sophisticated methodologies, genetic and neuroimaging technologies, these things are further cleared. Reduced hippocampal volume has been reported in depression and schizophrenia, and a recent study examined the association between myelin-related genes and the clinical characteristics of 280 schizophrenia subjects, specifically the presence or absence of depressive comorbidities. So most of these studies are not suggesting that probably this was only schizophrenia, not depression, but we were treating comorbidly. Depressive symptoms are common in patients with schizophrenia, yes. They add further to the disability of schizophrenia, including being associated with heightened risk of psychotic relapses, yes. PPD may be a particular forme fruste of major depression in schizophrenia. After the schizophrenia patient is in remission, there is some evidence far from conclusive that medications might directly impact depressive mood and suicidality. To some extent, that is not simply less depression because of less psychosis. And although intuitively appealing, there is insufficient evidence in literature to support the proposition that this represents a distinct subgroup of schizophrenia, schizoaffective. Lastly, substance abuse. There are multiple studies related to it. Consequences of substance abuse in patients with schizophrenia: more positive symptoms, relapse of psychosis, heightened risk of violence, heightened risk of suicide, more medical comorbidities, legal complications, and greater propensity to antipsychotic related side effects. Well, I know that this might have given you some more thoughts. जुबां चलने लगी, लब कुशाई करने लगे, नसीब बिगड़ा तो गूंगे बुराई करने लगे, हमारे कद के बराबर ना आ सके जो लोग, हमारे पांव के नीचे खुदाई करने लगे. Well, this is just one way of explaining this. I agree to you that you may disagree with me, yes. But again, we can have more discussions and a debate related to it. I'm willing for a debate and a challenging debate. In December, if I'll be coming over to Pakistan, then we can sit and have a debate on this. I will try to respond and to all of your questions, but my idea is schizophrenia is schizophrenia. Schizophrenia should be treated as schizophrenia. Schizophrenia should not be treated by polypharmacy. Schizophrenia should be treated very empathetically, emotionally, just imagining how much these people lose in their lives. Just imagine how much these people suffer in their life. Just imagine what is the state of affairs of their physical health, psychological health, and social health. What to say? ना वो नमाज पढ़ सकते हैं, ना वो बच्चों के साथ उनकी खुशियों में शरीक हो सकते हैं, ना वो लोगों के साथ मिक्सअप हो सकते हैं, ना वो लोगों की महफिलों को एंजॉय कर सकते हैं, ना वो मेरे साथ डिबेट कर सकते हैं, आर्ग्यू कर सकते हैं. वो लड़ सकते हैं, गुस्सा कर सकते हैं, लेकिन कन्विंसिंगली डिस्कशन नहीं कर पाते. कभी किसी स्किज़ोफ्रेनिया के पेशेंट को कन्विंसिंग डिस्कशन करते हुए सुना है? आपको किसी स्टेज पे आके लगना शुरू हो जाएगा, ओ यार छड़ पर आते पागल है. Imagine this height of frustrated state when these kind of statements are given to you. What will happen to you? You will definitely suffer from a comorbidity then. And this comorbidity should not be treated with medication. This comorbidity should be treated with passion, with empathy, with care, with intervention related to the surrounding thing. Ideally speaking, if I'll be an ideal psychiatrist, I will go for so many other things in ideal world. But of course, I know that I'm not practicing in ideal world. And the passion I have for my patients cannot be fulfilled. Sometimes when I have time and I sit in my clinic and I talk to my patients, I talk to them. Again, the same patient who's coming with me for, I'm seeing for years and years, I sit with them and I talk to them for hours. But of course, that is not possible every day. कभी जलसे जुलूस हंगामे कर्फ्यू की वजह से छुट्टी हो जाए और टाइम हो और पेशेंट्स थोड़े हों, तो फिर आप मरीज को खुल के अच्छी तरह से देखते हैं और देखना चाहिए. So मैं वही बता रहा हूँ, if in an ideal world situation, if I am practicing psychiatry, I will practice psychiatry with passion, not only with giving polypharmacies to my patient. Thank you very much for listening.